Our next speaker is Dr. Nelson Watts. He's professor of medicine, University of Cincinnati, and director of the University of Cincinnati Bone Health and Osteoporosis Center. He received his bachelor's in medical degree at North Carolina. He was an intern in Georgia and a resident at North Charlotte Memorial Hospital, and a fellow in endocrinology at North Carolina Memorial Hospital and Chapel Hill. He was a former professor at Emory before moving to Cincinnati. On his resume, the thing that really jumped at me was he's a former outstanding speaker at this meeting, 1998. To me, that was the nicest thing on the resume. But yeah, he was still in high school then. You know, this is actually his fourth appearance at this meeting, and he's editorial board of a number of journals, and he's been president of the American College of Endocrinology, International Society for Clinical Densitometry, numerous papers, and he's going to talk about long-term use of bisphosphonate, fact and fiction.
Sure do know how to make somebody feel old. Thank you. So Mike did a wonderful job of summing up the state of the art. I think about half of his talk was devoted to treatment. All of my remarks are going to be addressed at the safety issues involved with therapy, which I think is appropriate because in my typical 15-minute return visit patient, I spend at least 2/3 of my time talking about side effects and safety concerns. And I have precious little time to emphasize the risks of having osteoporosis and not being treated. One of our local rheumatologists was quoted on NPR in our community when Vioxx was taken off the market, and I've used this frequently with patients. He said, if a patient gets in their car, drives to my office to discuss their safety concerns about a drug like Vioxx, they have exposed themselves to greater risk in the drive than they would if they'd just taken the medication and not asked questions. So asking questions is risky. I see Dr. McClung frequently. In fact, he and I were in Chicago together on Friday. We're on advisory boards and speak and do clinical trials for all the companies in the field. So these are the drugs that are out there to use for osteoporosis. 4 drugs are approved to use for osteoporosis in men. Those same 4 drugs are approved for use in glucocorticoid-induced osteoporosis, and those plus some others are approved for treatment of postmenopausal osteoporosis. So I'm not going to raise any safety concerns for specific indications, but we'll certainly focus on those 4 drugs that are sort of there across the board. But rather than just limit this to bisphosphonates, I want to talk about safety concerns for all the drugs that are in the column here for treatment of postmenopausal osteoporosis. So one way to start is with calcitonin. And every time I hear Dr. McClung speak, I learn something. Every time I prepare for a talk, I learn something. And here I learned that nasal calcitonin may lead to a reduction in plasma lithium due to increased urinary clearance of lithium. That's not a particularly important point for me since I hardly ever use calcitonin long term. Major issues here are nasal irritation and epistaxis. Remember, early in the days of treating osteoporosis where people were concerned about theoretical issues with bisphosphonates, some of which have continued to bounce around, said, well, calcitonin is a much safer drug. And I said, well, let's think outside of medicine for a moment. If you're driving your car, water is probably safer than gasoline, but you wouldn't put water in the tank. Raloxifene, side effects, and I try to distinguish for patients between side effects and safety concerns. Side effect would be if you take this drug, you might get hot flashes and leg cramps. Safety concerns, the black box about venous thromboembolic events and possibly increased death from stroke. And here it says in the package insert, VTE occurred in about 1 out of 100 patients treated with Evista. This was over a 2.6-year exposure. Okay? So I had a patient this week who came in and said, we talked last year about bisphosphonates, but I didn't fill that prescription. Why she came back, I don't know. But I'm really concerned about the safety issues that I read in the newspaper. I said, well, I have a drug that doesn't cause atypical femur fractures and hasn't been associated with osteonecrosis of the jaw. She said, oh, great. I said, but nothing in life is risk-free, so you could take Evista, but then you'd be at risk for blood clots and possibly dying from a stroke. She said, oh, no. Teriparatide, the one anabolic agent, and at least in theory offers things that the other drugs don't, has a black box warning about osteosarcoma. Clearly, there's an increase in rats receiving very high doses for very long periods that doesn't appear to apply to people, so that's the safety concern. Side effects, nausea, lightheadedness, leg cramps. Denosumab. This is interesting. If you read the prescribing information, it says the most common adverse reactions reported with Prolia are back pain, pain in extremity, musculoskeletal pain, hypercholesterolemia, and cystitis. Well, someone asked, would you give an IV bisphosphonate to someone who had musculoskeletal pain with an oral bisphosphonate? I wouldn't, but I prescribed this drug, and patients would say, well, I was complaining about back pain, musculoskeletal pain with my bisphosphonate. Why would you give me this drug, which clearly causes these side effects? And side effect is the language used in the patient med guide. But when you look at the incidence in the clinical trials, yes, back pain occurred in 34.7% of patients receiving the study drug, but also occurred in 34.6% of placebo-treated patients. And generally, I don't have to go beyond the first line or two in discussing this with the patient before they realize this isn't helpful information. So what are the potential side effects? I don't know. Potential safety concerns are infection, cellulitis, and oversuppression. There's now a 2-year extension from the main 3-year trial that doesn't show any increases in those potential side effects. And there are 3 large trials of denosumab in higher doses used to treat skeletal complications of cancer that have not shown increases in infections or oversuppression of bone turnover. Osteonecrosis of the jaw, which we'll talk about with bisphosphonates, has been reported with denosumab and would appear to be a potential consequence of any potent anti-resorptive drug used long-term. I think one of the reasons that we're concentrating on bisphosphonates, and this is my segue into the bisphosphonate area, is that these 3, alendronate, risedronate, zoledronic acid, have evidence in placebo-controlled trials for what I call broad-spectrum anti-fracture efficacy. Not only vertebral fracture risk reduction, but also non-vertebral fracture as a collective endpoint and hip fracture as a specific endpoint. And denosumab now has that same broad spectrum, but it's a new drug, and we've had alendronate around since 1995. So we've gotten some information. I was going to say we've learned something since the drug's been on the market. I'm not sure how much we've learned, but we certainly have some new information. Etidronate came along in 1977. It actually was a compound discovered back in the 1850s, but medical use is fairly recent. Now, I was involved in studies of this drug for osteoporosis. It made it to the market everywhere else in the world, but not in the U.S. The first, quote, non-hormonal therapy for osteoporosis was alendronate that came along in 1995, but many of us were using pamidronate off-label for treatment of osteoporosis, a parenteral bisphosphonate. Then along comes risedronate for oral therapy, and then abandronate for oral therapy, then zoledronic acid and abandronate for IV therapy. So the dosing started with daily dosing, and the routine, as you know, involves first thing in the morning after a prolonged fast, nothing but water, waiting 30 minutes for adequate absorption, no food, no coffee, no other medications, and staying upright, sitting, standing, moving around. And for me, that wouldn't be a problem, but many of my patients says, I have to have coffee first thing in the morning. I have a life, I've got to get on with it. And so weekly